Experience it here. Step into a world of inspiration at the 2024 ASCO Annual Meeting, where the thrill of scientific discovery and the power of global connections converge. Join us in Chicago, May 31st through June 4th. Register now at am.asco.org.
Hello and welcome to the ASCO Daily News Podcast. I'm Dr. Shaalan Beg, your guest host of the podcast today. I'm an adjunct associate professor at UT Southwestern's Simmons Comprehensive Cancer Center and vice president of oncology at Science 37. Today, we'll be discussing key abstracts and other exciting highlights from the 2024 ASCO Gastrointestinal Cancers Symposium. Joining me to discuss some key takeaways from the meeting is the chair of this year's symposium, Dr. Rachna Shroff. Dr. Shroff is the Division Chief of Hematology Oncology and Chief of GI Medical Oncology at the University of Arizona Cancer Center. She also serves as the Associate Dean for Clinical and Translational Research at the University of Arizona College of Medicine, Tucson. Our full disclosures are available in the transcript of this episode, and disclosures related to all episodes of the podcast are available at asco.org/dnpod. Dr. Shroff, welcome back to the ASCO Daily News Podcast, and congratulations on a great symposium. The scientific advances and innovative multidisciplinary approaches featured throughout the meeting were really inspiring and reflect incredible strides we're making in GI cancer research.
Thank you so much for having me back. I'm delighted to be here.
Dr. Shroff, the theme of this year's symposium was taking personalized care to the next level. I'd love to hear your reflection on the sessions that you found most exciting and really resonated with the attendees.
Yes, thank you. We were really excited about this theme because we really felt that taking personalized care to the next level translated to thinking through personalized approaches to patient care, not just in the traditional ways that we think of with precision oncology and genomics driving our care, but also how we can really think through multidisciplinary approaches in an individualized care plan, thinking through how artificial intelligence and novel clinical trial designs can and should be implemented to meet the needs of our individual patients. And so we really highlighted that in what was a somewhat new reboot of a session called Intersections, which were every day and were really more cross-tumor. They were tumor agnostic, but were thematic focused. As I mentioned, those themes were really based on feedback that we've had from prior attendees, as well as from the program committee's feeling on what is really the questions that we are dealing with and that are burning in clinic today. And that includes the emerging role of artificial intelligence and machine learning and how we integrate that into our clinical care, approaches to oligometastatic disease. And it's not really just something that we think of in colorectal cancer, but how can we use that paradigm to really apply it to other GI malignancies? And then the art and science of clinical trial design, where again, traditional randomized phase 3 trials might not be the best and most innovative and most expedient way of bringing novel therapeutics to our patients. And so all of those sessions I thought were really highlighting different important topics that we deal with day to day. Additionally, we had a really fantastic keynote lecture from Dr. Kimmy Eng from Dana-Farber. She's a world-renowned expert in the early onset colorectal cancer space. And the timing of her keynote was perfect with the new cancer statistics that came out literally days before GI ASCO that demonstrated this just dramatic rise in early onset GI malignancies as a whole, not just colorectal. And so she spoke really in a comprehensive manner, not just on clinical approaches, screening approaches, and how to find these patients at an earlier stage, but also kind of gave us a call to action, if you will, in terms of public health initiatives, as well as, like I said, clinical care and really thinking outside of the box for how to reach these patients. And then, of course, we always have what I think is one of my favorite aspects of the meeting, which are the networking opportunities that include the trainee and early career networking luncheon, the women's networking reception, and the Meet the Experts luncheon, where especially as junior career investigators, you have an opportunity to meet what we think of as the quote unquote big names in GI cancer.
Absolutely. I remember my first couple of GI ASCO meetings, and those were probably the most memorable sessions that I attended as junior faculty as well. So let's take a deeper dive into some key abstracts from the meeting. I'd like to begin with abstract 245. This is the Skyscraper 08 study. It's first-line tiragolumab and atezolizumab with chemotherapy in an Asian patient population with esophageal squamous cell carcinoma. What are your key takeaways from this study?
Yeah, this was an exciting study, in my opinion, in the sense that thinking through how we can build on immunotherapy backbones is obviously a pressing question across the GI cancer space. So this was a phase 3 randomized double-blinded placebo-controlled trial that looked specifically at patients with esophageal squamous cell carcinomas. And the study was enrolled fully with an Asian population. It looked at taking the traditional chemotherapy backbone and adding to it an anti-PD-L1 with atezolizumab and an anti-TIGIT with tiragolumab. Again, that proof of principle of using anti-TIGIT and PD-L1 has been looked at across a lot of different GI cancer spaces. And we know that the esophageal squamous cell cancers tend to be very immunotherapy responsive. So this was a really important question. This involved a number of patients, a little over 460 patients who were randomized 1-to-1 to receive the tiragolumab with atezolizumab with the standard paclitaxel and cisplatin that's used for esophageal squames versus chemotherapy alone with placebo. And the primary endpoint was independent review of progression-free survival and overall survival. And so out of the 461 patients randomized, there was, at the primary analysis, a median improvement in progression-free survival from 5.4 months in the control arm to 6.2 months with the tira plus atezo plus chemo arm, with a hazard ratio of 0.56, highly statistically significant. Similarly, the median overall survival was also improved from 11.1 months to 15.7 months, again with a hazard ratio of 0.7. And some of the other key efficacy endpoints were also improved with the addition of the anti-TIGIT PD-L1 approach. And importantly, there was not really safety signals that jumped out at us. And so to me, what this means is that in our patients with esophageal squamous cell carcinoma, we really should be thinking about chemotherapy with immunotherapy as a backbone and how we can build on it. And, I would imagine that it's hard to argue with both the PFS and OS endpoint that adding anti-TIGIT won't necessarily be kind of the new approach to these patients. And importantly, I'll point out that it seems to be a benefit across the subgroups, including PD-L1 status, which is always our big question here. I think the only thing to keep in mind is this was an all Asian population and whether or not that kind of immune profile and the immune responsiveness is different in those patients. But regardless, a positive phase 3 trial.
And really exciting to see immune checkpoint inhibitors or immune therapy beyond PD-1 targeted, CTLA-4 targeted treatments making their way into GI cancers.
Absolutely.
Sticking with the immune therapy theme, let's focus on hepatocellular carcinoma. So LBA 432, the EMERALD-1 study of transarterial chemoembolization combined with durva, with or without bevacizumab, looked at people with unresectable hepatocellular carcinoma eligible for embolization. This is really a highly anticipated study. I'm wondering what your thoughts are and whether it'll be practice changing for this field.
I was really excited to see the press release when it showed that the study was positive. And I think it's because now that we're using immunotherapy in the advanced HCC space, our obvious question is can we integrate it into multimodality approaches? And, there's a lot of kind of smaller studies looking at neoadjuvant IO approaches. And then, of course, in this intermediate stage, unresectable cholangiocarcinoma, hepatocellular carcinoma patients, we wanted to know if there was a utility to liver-directed therapy with immunotherapy. So this was a large study. It was a global study looking at unresectable HCC with preserved Child-Pugh function, but it was Child-Pugh A and up to B7, importantly. And there were 616 patients that were randomized in a 1-to-1-to-1 fashion, with the control arm being just TACE alone. But then there was an opportunity for durvalumab with TACE, as well as durvalumab plus bevacizumab with TACE. And the patients would receive durvalumab during their TACE treatments and could receive up to 4 TACE treatments. And then subsequently were either continued on durvalumab alone, durvalumab plus bevacizumab, or the placebo. And the primary endpoint was progression-free survival, and powered specifically to look at TACE versus durva bev plus TACE. And in this study, the primary endpoint was met with a significant improvement in PFS. Median PFS was 15 months versus 8.2 months with a hazard ratio of 0.77. And again, most pre-specified subgroups demonstrated this benefit. Importantly, there was a secondary endpoint looking at the durva plus TACE versus TACE alone, and that actually did not show a statistically significant improvement in median PFS from 8.2 months in the control arm to 10.0 months. The overall response rates were slightly higher with the durva plus bev approach at 43.6%. And importantly, in these patients with, oftentimes a higher burden of disease in the liver, median time to progression is a really important and clinically meaningful endpoint. And that was 22 months with the durva bev plus TACE versus 10 months for TACE alone. And I would just point out that the overall concern that we always have with bevacizumab is, are there increased risks of bleeding? What is the treatment-related adverse event profile? And really, overall, there was no safety signals that emerged from this, with nothing that really, especially in that bleeding risk category, jumped out at us. Of course, we haven't seen the overall survival data yet because we have not seen enough follow-up to really see that number. I do think that this is potentially practice changing. And I think it just demonstrates that there's probably some synergy between anti-VEGF with anti-PD-1 and then the liver-directed treatments. I think the obvious question for us in the United States is, there's a vast majority of people who are moving away from TACE and moving towards more TARE or radioembolization. And what can we extrapolate from this? Does this really tell us much if people are using more of a Y90 based approach? I think those are a lot of the burning questions that most of us have.
Yeah, and a very interesting direction that the HCC space is taking, because we heard in previous meetings the role of PD-1 inhibition as adjuvant therapy after resection. Now we have data for local regionally advanced disease or local regional treatments. And of course, you already mentioned the data for more advanced disease. So it sounds like immune therapy may be impacting the management of anybody diagnosed with hepatocellular carcinoma. Let's talk about the MONET trial, abstract 249, which compared thoracoscopic esophagectomy and open esophagectomy for thoracic esophageal cancer. Do you think this is a study which may influence the treatment of patients with thoracic esophageal cancer?
So this was, again, I think a really important question. And it was a randomized controlled phase 3 trial comparing a more minimally invasive approach with, I'm going to say TE, thoracoscopic esophagectomy, versus an open approach. And this had patients with clinical stage 1 through 3 that excluded T4, thoracic esophageal squamous cell carcinomas, and they were randomized 1-to-1 to the open versus the TE approach with a primary endpoint of overall survival and an important secondary endpoint of relapse-free survival. And 300 patients were randomized. And at the second planned interim analysis, the median follow-up was a little over 2.5 years, and the 3-year overall survival was 82% in the TE group versus 70.9% in the open group. And so the DSMC of this trial actually recommended early termination based on the non-inferiority, which is what they were specifically looking at. And there was a very statistically significant one-sided p-value for non-inferiority. And importantly, the 3-year recurrence-free survival was also markedly better in the TE group versus the open group, with no real notable differences in R0 resection or a large percentage of patients who needed to be converted from a TE to an open approach, and really not any significant difference in overall post-op morbidity. And so, I think this just supports the concept that, minimally invasive approaches for our patients with GI malignancies can and should be considered. Again, esophageal squames, because they're tending to be seen a lot more in Asia. This was a study that was conducted in Japan. And, I think that being said, a lot of our surgeons in Europe and in the US are also very amenable to minimally invasive approaches. And I think this just supports the fact that an open approach is not necessary. So I would think, again, that this is something that is implementable and I think will affect the field.
Moving on to metastatic cholangiocarcinoma, there have been many FGFR inhibitors that have shown activity and promise and are approved for the management of cholangiocarcinoma with FGFR alteration. But this ASCO GI, we heard the results of the safety and efficacy of an FGFR 1, 2, and 3 inhibitor, tinangotinib, as monotherapy for advanced metastatic cholangiocarcinoma. How do you see this fitting into the broad picture?
Yeah, so this was highly anticipated data, primarily because at this point, the FGFR space in cholangiocarcinoma is quite crowded. And so a lot of us we're getting sick of the Me Too drugs. And what is really unique about tinangotinib is that not only is it a selective multikinase inhibitor, but it actually in preclinical models as well as in early phase 1 trials demonstrated potent inhibition of patients with FGFR2 fusions and rearrangements who had acquired resistance mutations. So as we better understand the first generation of FGFR inhibitors and know the resistance mechanisms, these drugs are now being developed to try to circumvent or overcome those. And so this study looked at 4 different cohorts. One cohort with FGFR2 fusion patients who had primary progression, who never responded to FGFR inhibitors. The second cohort was those patients with FGFR2 fusions with progression after primary response, so those with acquired resistance. Then there was non-fusion FGFR alterations, because we do know that a number of cholangiocarcinoma patients have other FGFR alterations that are not fusions. And then those with FGFR wild type. And the primary endpoint was objective response rate with a total of 48 patients enrolled across the 4 cohorts. And so the 40 patients who were evaluable in the group that had primary resistance, which was the first cohort, there was a response rate of 9.1%. That was partial response, and then 31% who actually had tumor reduction with tunigatinib. And similarly, in those who had acquired resistance, 37.5%, 3 out of 8 patients, had a partial response, and tumor reductions were noted with an overall disease control rate between those patients with FGFR2 fusions of 94.7% between those who had primary and secondary resistance. In the patients who had FGFR alterations, there was a third, 3 out of 9 patients who had a partial response. And again, tumor reduction was notable across the board, and a disease control rate was seen at 88.9%. The other group, the FGFR wild type group, not surprisingly, really did not see any partial responses. But interestingly, 75% of patients with FGFR wild type had at least disease control. And the median progression-free survival was 5.26 months. Again, kind of most notably impressive in the 2 cohorts that included FGFR2 fusions. The toxicity profiles are what we've come to expect from FGFR inhibitors. And again, really, we've gotten better at managing those and mitigating some of those. So there was really nothing that jumped out there. And so there's now an ongoing randomized phase 3 trial that's really specifically looking at tunigatinib versus physician's choice in patients with FGFR2 altered cholangiocarcinoma after having received prior FGFR inhibitors. And so that's where I think it fits in, is for those of us who know that there are multiple drugs in this space, our big question has been, can we sequence through them? Can we offer multiple FGFR inhibitors to these patients? And I think we're all eagerly anticipating this data as well as the subsequent data to really justify the use of these novel second generation, if you will, FGFR inhibitors.
And it's been fantastic to see the evolution of these compounds and, it's precision medicine or precision oncology at its finest in terms of understanding mechanisms of resistance and treating refractory disease. So let's focus on colorectal cancer. I'll tell you, there's been a lot of discussion, Dr. Shroff, on social media, on insurance companies, sometimes rejecting one biologic or the other based on tumor-sidedness. We have talked about tumor-sidedness predicting response on this podcast based on data from previous studies. But this year in GI ASCO, Abstract 207 explored the role of tumor genomics and tumor-sidedness. And they said that it's tumor genomics, that tumor genomics better explains the differences on outcomes and it explains it better than sidedness. What does this mean to the field? Because a lot of professional organizations have guidelines that are asking people to now incorporate sidedness. So how does that change based on these results?
Yeah, I really commend these authors on leveraging real world data. And I think we're getting better and better at recognizing that real world data actually informs our clinical decision making, possibly better than sometimes some of these studies that lead to the guidelines and the algorithms that we've developed. So this is, I think, a perfect example, a little bit of cart before horse and trying to really understand the way that sidedness and genomics may interplay. And so this was a study that basically leveraged both the Foundation Medicine and the Flatiron Health clinical genomic database and looked at patients with microsatellite stable metastatic colorectal cancer. There was a total of 3,845 patients included in a kind of a 2/3, 1/3 split between left-sided and right-sided colorectal cancer. And they found the typical genomic alterations that historically have been thought of more with left-sided colorectal cancer, like APC, and then more of the RAS-RAF alterations more in the right-sided patients. But what they really thought, what I think was really remarkable, is they really looked at the patients and how they received chemotherapy with anti-EGFR or bevacizumab therapies and did a multivariate analysis to really see what is driving outcomes. And like you mentioned, what they found is that patients in the RAS pathway, those classified as having alterations in the RAS pathway, had less favorable outcomes, while those with the APC altered group had more favorable outcomes. And that was really regardless of treatment received and sidedness. And so when they kind of did an analysis of what was called a likelihood ratio test, they found that when genomics was added to the sidedness evaluation, there was an improvement in outcome prediction, but not when sidedness was added to genomics. And so it's like you said, it kind of demonstrates, at least in this mining of real world data from Flatiron, that tumor genomics is probably a better driver and a more important driver in determining outcomes than sidedness. I completely agree with you. I would push for us to really kind of bring a little bit of noise to this and to make insurance companies and other companies that are looking at this think through this a little bit more and make sure that we're putting all of the data together in a comprehensive fashion before making treatment plans and determinations.
The last abstract I'd like to ask you about is abstract 117, the NEST-1 trial. And this looked at neoadjuvant botensilimab and balstilimab for resectable, mismatch repair proficient, and deficient colorectal cancer, so both MSS and MSI. And what are your key takeaways from this study?
So this is another study that is demonstrating that there may potentially be a role for immunotherapy in microsatellite stable patients. And, I will make the caveat that this was a single arm study that really was looking at feasibility, safety, with efficacy as kind of a secondary endpoint, but at the combination of bot/bal in a neoadjuvant space for colorectal cancer patients. And so they received the 1 dose of the bot and then 2 fixed doses of bal 2 weeks apart, and then were taken to surgery. They limited, out of the number of patients in this, out of the 12 patients that were enrolled, they limited the number of patients that were mismatch repair deficient. So to your point, they allowed both, but they wanted to make sure it was not just MSI high patients. What they basically found is that it was safe and it did not delay surgery or increase any risks of adverse events. But importantly, there was significant regression of tumor noted and some interesting kind of spatial biology analyses that demonstrate some maybe potentially novel mechanisms of actions, and especially in the MSS population, and that ctDNA reductions correlated with pathologic response. So there was a lot of different things that they were looking at, but basically suggesting that bot/bal is safe and can be used in both mismatch repair deficient and proficient patients with colorectal cancer. And now, importantly, they've added some additional cohorts and they're expanding the study because, like I mentioned, this is right now just 12 patients, but does definitely have a provocative signal.
Thanks so much, Dr. Shroff. And finally, the role of ctDNA in GI cancers has been a really exciting and important development in our field. There's tremendous data that emerged at the GI meeting, and we've decided to do a separate ASCO Daily News podcast dedicated to ctDNA. So listeners, please look out for our coverage of key studies on ctDNA and GI cancers very soon here on the ASCO Daily News Podcast. Many thanks, Dr. Shroff, for sharing your insights with us today and for your great work to build a robust GI meeting this year. Thank you very much.
Thank you so much.
And thank you to all our listeners for your time today. You'll find links to the abstracts discussed today on the transcript of this episode. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.